Hi guys, my name is Mark Noonan in cell biology, and today we will be looking over my project, which is on Gaucher disease. Alright, so without further ado, let's get into it. This presentation will be on Gaucher disease. I know it looks like it's pronounced Gaucher, but it's pronounced Gaucher. Alright, so what is going on in Gaucher disease? There is a deficient enzyme production called glucocerebrosidase within the cell. This enzyme functions to hydrolyze glucosylceramide into ceramide and glucose. And without this enzyme, there is a buildup of Gaucher cells into tissues. And basically what a Gaucher cell is there is an accumulation of fat within those cells. And so here is a picture you see underneath of Gaucher disease, and without the enzyme, there is an accumulation of these fats, and they're not getting broken down into glucose or ceramide. So there are three types of the disease. Type 1 is characterized by the presence of bone disease, hepatosplenomegaly, which is the enlargement of the liver and spleen, thrombocytopenia, so insufficient blood production, and the absence of CNS defects. These people can expect to live a normal lifespan, as opposed to types 2 and 3. Both of these are characterized by central nervous system defects. Type 2 is the more severe, where it has a rapid decline in central nervous system. This occurs before age 2 years. It normally occurs during the first year of life, and the life expectancy for most of these patients, it is under 2 years, but they can on occasion live up to 4 years. And then there's type 3, which is also caused by central nervous system defects. This one is more gradual than type 2. It begins in early childhood, so not quite in infancy like type 2. And then the people who have this can expect to live between 30 to 40 years. So within the cell, the lack of glucocerebrosidase makes the hydrolysis of fats very difficult, as we said before. So if you look at the picture here, they're not able to get the products, which are ceramide and glucose, and then there's accumulation of the substrate within the cell. The reason for this is that there is a problem with the lysosomes, and as we'll go into later, Gaucher disease is classified as a lysosome deficient storage disorder. And then the accumulation of these fats within the cell leads to what's known as a Gaucher cell, and these have been known to infiltrate tissues, which is what causes the symptomatic effects of this. And then for those with type 2 and 3 of the disease, there's excess release of calcium from the endoplasmic reticulum and a dysfunction within the mitochondria. And as we know from the endoplasmic reticulum and mitochondria, this could lead to differences in membrane potential, ATP function, and increased reactive oxygen species levels within the cell. And then so now we can zoom out a little bit and look at the organ and organ system level. So these Gaucher cells are known to infiltrate organs, leading to complications such as cytopenia, splenomegaly, hepatomegaly, and bone lesions. These are kind of the hallmark symptoms of the disease, and most of the time when people see hepatosplenomegaly, that's kind of what they think is that this might be Gaucher disease. So splenomegaly is the most common, affects up to 85% of patients. And then, as we talked about, thrombocytopenia is very common. So this is where there's insufficient thrombocytes, and this causes an increased risk of bleeding because there is a low level of platelets, which normally helps in the clotting process. And then this can also cause necrotic bone complications due to vascular compression. So if there's not enough blood supply getting through to the bones, there's death of that tissue, which causes the necrosis of the bones. Now, if we finally zoom out even a little bit more, past the organ and organ system level, we see that there are even more complications. Those with Gaucher disease have a 5 times higher risk of developing gallstones. With this, there is an impaired function of the gallbladder, which acts to store bile and help in the fat digestion process. So a lot of times people have to have their gallbladder removed if they have these symptoms. This also may lead to pulmonary fibrosis or pulmonary arterial hypertension if these cells infiltrate the lungs. This is probably a little bit less common, but is definitely still possible, just depending on where the Gaucher cells infiltrate. And then if we have, again, we mentioned hepatosplenomegaly. This is what occurs in most patients. You'll see an enlarged liver and spleen. And this places increased demand for blood flow and puts more pressure on the other digestive organs as well. And then there's also, as we talked about earlier, the lack of blood flow to the bones, high risk for bone pain, avascular necrosis, osteoporosis, and spontaneous fractures. Again, these are the accumulation of fats in the bone marrow leads to insufficient blood production, and then that can contribute to these conditions here. So is this disease inherited? Yes, it is. This Gaucher disease is an autosomal recessive disorder. They both have a pathogenic variant of the GBA1 gene. And then here are some statistics for the likelihood of getting this disease if both parents are carriers. So these percentages kind of match up with the picture. So if you want to take a look at the picture here, you have a mother and a father who are both unaffected carriers. There's a 50% chance that the offspring will be a carrier, which means that they will be heterozygous for the normal gene, in addition to the pathogenic variant of that gene. They'll have a 25% chance of not being affected at all, being homozygous dominant, but then they'll also have a 25% chance of inheriting the disease, which is where that homozygous recessive comes in. So how many people have this disease? I'm going to assume a lot of you haven't heard of the disease. I had not previously. So what's unique about this is that this disease mainly affects those of the Ashkenazi Jewish population, where there's approximately 1 in 450 who will have this disease, and then this number drops to about 1 in 100,000 for the American population. So as we looked at earlier, we looked a lot at the cell cycle and cell cycle checkpoints. This is not caused by a failure at any of these checkpoints, so you're not going to notice any uncontrolled cell growth or inhibition. The only thing you're going to notice is just an accumulation of those cells with a lot of fats in them. So as mentioned previously, this is a lysosomal storage disorder. So after glucocerebrosidase is initially synthesized in the ER, it goes to the lysosome where the enzyme gains additional function. And then there have been over 200 missense mutations associated with Gaucher disease, most of them affecting the lysosomal protein. As we look at in a couple slides here, this number has actually increased to 600 missense mutations. So with the increase in biotechnology, they are continuously identifying more and more mutations for this. And as you can see from this picture here below, glucocerebrosidase right there in the middle represents Gaucher disease, but there are also other lysosomal storage disorders, namely Tay-Sachs, which is another relatively common one. So there may be some other environmental or epigenetic factors that influence the expression, but these factors are not well known. Um, so as of right now, it's mainly just the genetics, and they're still trying to identify any potential environmental factors. Um, so there aren't really any diseases that cause Gaucher disease, but Gaucher disease has been associated with a higher risk of Parkinson's for those who make it to the age in type 1, that GBA1 gene variant that is also very common in those with Parkinson's disease, so there is a link between those two. So this GBA1 gene, primarily located on chromosome 21. Again, I mentioned earlier that there were 200 missense mutations, but now within the last few years, we've uncovered several more. So now this number is up to 600. And these are all related to, again, GBA1 can be Parkinson's or it can be Gaucher disease. So some testing. Yes, there's testing available. A lot of it is available during pregnancy. It is recommended for those with a family history or if somebody is a carrier of the disease. So during pregnancy, if you're 8 to 10 weeks pregnant, there is a chorionic villus sampling. At 15 to 17 weeks, you're able to do amniocentesis, which is this picture on the right here. That one represents amniocentesis, where they get the amniotic fluid and run their genetic testing that way. And then there's also blood testing available for newborns and those in your childhood as well to test for that glucocerebrosidase enzyme. And then, as mentioned earlier, this GBA1 mutation is also associated with Parkinson's disease, which could cause an issue in testing, but not really, because Parkinson's disease usually manifests later in life, whereas Gaucher disease kind of comes on earlier, but this may cause an issue if you're continuously getting tested for it later in life. And then another issue with the blood test is that you're unable to distinguish between those who have the disease and those who are carriers. So basically, whether or not you're homozygous recessive or heterozygous, it's unable to distinguish between that. However, there are other ways of determining this, kind of based on clinical presentation and symptoms, such as hepatosplenomegaly, like we mentioned earlier. So what are they looking for in this blood test? So they're looking at the levels of glucocerebrosidase, and these are typically 0 to 15% of the normal value. So this is quite a big difference from what you'll normally see. And this test, it is available for primary care physicians. However, a lot of physicians overlook the idea of somebody having this disease, so they normally won't order it. They will kind of go more along the lines of a mainstream disease, not one quite as rare as this one. But if they do order this test, it is available. Most of the time, though, it is ordered for those with a family history, or if there are other signs and symptoms such as hepatosplenomegaly. So now let's get into some treatments here. Unfortunately, there are no preventative measures for this disease, and I will say that there are no cures for this disease, but there are options to minimize the symptoms. The most common of this is enzyme replacement therapy, which is a product called imaglucerase, which is a modified form of glucocerebrosidase, isolated from human placenta, and it's been approved for use for about 35 years, so it's pretty trustworthy and has been regarded as safe. Kind of the gold standard for minimizing the symptoms in types 1 and 3 for this. And then the goal is just to replenish that deficient enzyme, and then that way there is less accumulation of fats within the major organs. In this picture here, I showed a nurse giving medication intravenously, which is how enzyme replacement therapy is delivered. So yes, you'll have to go in and have this medication delivered throughout your life. Another option is substrate reduction therapy, and this is indicated anytime enzyme replacement therapy is not an option. It's kind of the second line treatment for this. The goal is to reduce the rate of glycosphingolipid synthesis, and then this kind of restores the balance between synthesis and breakdown, again, with that common goal of minimizing fat accumulation. And then also used for types 1 and 3 of this disease. The only benefit of this one is that it's delivered orally rather than intravenously. However, there's a high tolerance to this, and the medication dosages may need to be increased over time. And so again, this is a genetic disorder on that GBA1 gene. So you might be thinking, what about gene therapy? Well, unfortunately, this has shown disappointing results, and it's not used as the main treatment. But hopefully with biotechnology and all the advancements that we're making, that one day gene therapy will be feasible. And then other treatments are regarding the symptoms. So any kind of bone pain, there are analgesics that can be used, such as Tylenol. And then a lot of them are just related to organs themselves. So any bone fractures, any surgical treatments, such as sometimes the liver is severely dysfunction. People go into liver failure. They may need a transplant, and then they may need surgical interventions, which I have provided in the pictures below here. So we mentioned enzyme replacement therapy and substrate reduction therapy. Unfortunately, those do not work for type 2. There's still no management or treatment options for those with type 2. The reason for this is that this disease involves the rapid progression of neurological impairment. This usually manifests in the first few months of life. And these forms of treatment that I mentioned earlier are not able to cross the blood-brain barrier. And so this results in the rapid decline of neurological function. And they usually die relatively early in life. So there's currently a lot of research that's being done on this disease, particularly types 2 and 3, which involve that neurological impairment. But again, I've talked a little bit about the biotechnology and how that kind of provides an optimistic outlook for types 2 and 3, including they've had these pharmacological chaperones that have been used to help molecules cross the blood-brain barrier. And the results for these have been mixed. In one study, the results were relatively negligible, and it still wasn't able to cross the blood-brain barrier. And then in another study, it was able to cross the barrier and decrease the incidence of epileptic seizures in those with types 2 and 3. However, unfortunately, it's still not prolonging the lifespans of these people. However, there's hopes that those with types 2 and 3 will eventually have their cognitive impairments managed, and that it's able to cross. So here I provided a picture of the blood-brain barrier, and certain molecules are able to cross. It's a very sensitive. Obviously, we can't have all sorts of chemicals, and we don't want all sorts of chemicals crossing over this barrier and getting into our brain. So it's one of the highly researched topics is how to get medications cross there. So what can us health practitioners do to help? One is recognition of the disease. Most people do not know about this disease. And there was a study that said on average, those with Gaucher disease visited 3 physicians before receiving a correct diagnosis. And any of these delays in diagnosis and management can have fatal consequences or very painful consequences. Again, any sort of symptoms such as osteonecrosis, GI bleeding, bone pain, fractures, and liver disease as well. And that concludes my presentation here. These are my references, quite a lengthy list here. All right, thank you guys for listening to my presentation. I hope you were able to learn something about Gaucher disease. Please let me know if you have any questions.